insulin non-adherence, reasons and impact. So dear doctors, we all know that we are aware of insulin as a vital life-saving drug in diabetes patients. And among the various modifiable and non-modifiable barriers to the medication adherence in diabetes, affordability for insulin is one of the major issues and especially a global concern these days. Hence, to discuss the consequences of high-cost insulin and to share us with the important clinical implications, we have with us renowned endocrinologist from Bangalore, Dr. Kashinath Dixit, sir. Sir, a very warm welcome to you once again. Sir is a consultant physician and diabetologist practicing in the Gauri Kaurunga Diabetes Center and the Krupa Diabetes Center. He has a vast clinical experience spanning over 30 years and he is associated with the Krupa Diabetes Center for more than 30 years. He is also one of the members of the prestigious organizations of India like the RSSDI and the IMA. He has conducted mega camps year after year with a walkathon crowd. So once again, I welcome sir and now hand over the session to sir to share his clinical experiences and highlights of today's topic. Over to you, sir.
Thank you, madam. Yeah, good afternoon, friends. Next 15 or 20 minutes, I am going to just brief you about this insulin non-adherence, reasons and impacts. Just I will be brief, I will not bore you. What is this adherence we are talking? Adherence to insulin is a critical factor for adequate control of diabetes. We all know this. It's a very critical factor for the adequate control of diabetes. But despite the multiple known benefits of adherence to insulin, many people, they won't take regularly. We call that as poor adherence. What is this poor adherence or non-adherence we are talking? Whenever we prescribe any medicine to the patient, whether it's a insulin or oral anti-diabetic drug or whatever it is, if it takes at least 80% regularly for together, if it takes 80% of that regularly, we call it as adherence. If it comes less than 80%, then we call it as non-adherence. So I clearly told you what is adherence, what is non-adherence. And as I told you, next few minutes, we are going to talk about this non-adherence. The word non-adherence means whatever we advise, whatever a physician or a diabetologist advises, patients will not take the medicine regularly. Why? What are the reasons? And what is the impact of this non-adherence? That is, I am going to tell you. See, in other words, poor adherence, we call it as if they are not taking the medicines. In one of the studies done in UK, about 59.2% of the patients were adherent to the insulin. What I mean to say that nearly 40% of the patients, they were not adherent to the recommended dose of insulin. Either they were taking less or they were skipping or some other thing. Whereas with oral anti-diabetic drugs, it was 22%. 22% of the patients, they were not adhering to the medicine regularly. They were not taking medicines regularly. In other words, they were skipping the medicines in spite of telling. Why? What are the reasons? See, we talk so much of diabetes. We have so many medications. Oral, 5-6 types of oral medications, 3-4 types of insulin based and all those. And GLP-1 analogs we have. In spite of that, in the entire world, only 45% of the persons, 45% of the persons with the diabetes, they achieve the goal of less than 7%. And in one of the studies in UK only, it was clear in type 2 diabetes, about 30% of the all diabetic patients, they were on insulin alone, or along with insulin, they were taking oral anti-diabetic drugs, about 30%. In India, there are no studies. If I am correct, it's about 10 to 12% of our Indian patients, they are on insulin. Yeah, we'll come to the topic proper. Non-adherence. What does the word non-adherence mean? Whatever a physician prescribes, the patient or a diabetic person will not be taking the medicine regularly. What are the reasons for this? First one is the cost, it was mentioned. See, insulin, we have got a lot of insulin. traditional premixed insulin, basal insulins are there, then rapid acting insulin are there, lot of analogs are there. And analogs also we have got short acting, long acting. Insulin is quite expensive. See, premixed insulin, it comes in vials and cartridges. A premixed insulin of 400 units, if I am correct, it costs around 400 units. That cost will come to hardly about 50 paisa per unit. So probably traditional insulins, human insulins, free insulins, they are not so cost effective. But still, it's a factor, especially if we are giving more of insulin, say 30 units 3 times a day, rapid acting, things like that. It may cost about 100 or 80 or 90 rupees per patient. It may be expensive. But the traditional human insulin, they are not so expensive. Whereas insulin analogs, they are almost 3 to 4 times the cost of the okay. Yeah. And the cost I was telling. And if you compare the cost of cartridge versus vials, it will be hardly about 20 to 30%. If I am correct, 300 units of cartridge will cost about 160 rupees. Whereas same 400 rupees of vial will cost around 200 rupees. So 180 or 140 or 160 or something like that. So cost is not the barrier with the human insulin. Only if it is insulin analogs, the factor of cost will come. So non-adherence, probably cost may not be a factor. But for poor type 1 diabetic patients, it matters because they will be on high dose insulin. They will be not on any oral hypoglycemic drugs. So the cost burden will be there. But still, non-adherence cost is one of the factors I can say. Then second one is about 30 years back we had only 1 or 2 brands of this insulin. Now various 7 or 8 brand types of insulin, even premix also we have got about 7 to 8 brands in India. The availability will increase. In the city areas, most of the insulin cartridges or vials are available, but only in rural areas the availability will be a problem. It all depends on the pharma companies, how they aggressively, how they promote, and how they stock their medicines almost. Then the third factor is, I told you about cost, availability I told. And some of the patients will be reluctant to take it. Middle class, lower middle class, they will not be having the fridge or refrigerator facilities. This insulins we have to store it from 2 to 8 degrees or 4 to 8 degrees centigrade. They may not be having refrigerator facility. But if I am correct, this premix insulins, this vial or cartridge form, can be kept at room temperature for about a month. The bioavailability of that insulin will not come. So we can convince the patients. Then I was talking about non-adherence. Number of pricks also matters. If a patient takes just 1 prick in the night, usually basal insulins at night before going to bedtime they take. In that, the acceptance rate or the adherence is about 92% in one of the studies. Adherence, if they are taking only once a day. In one of the studies, it was 92%. They were adherent to that once a day insulin at bedtime. Whereas if we give rapid acting 3 or 4 times a day, the adherence will come down. In one of the studies, it was just 72%. This adherence is a vague terminology, varies from area to area and person to person. Then, as we all know, initiation of insulin is a major. However, how much ever we convince, the patients will be little hesitant. Especially to initiate a pen, usually what I do is, I have got a sample pen. See, this is the insulin pen. I'll just 5 to 10 minutes I'll spare with the patients. I'll just show them this is the needle and this is the cartridge. You have to fill up like this. Just 5 minutes I'll spend with each patient and this dialing facility, everything I'll demonstrate. You see, what we do in our busy schedule, we'll prescribe them the insulin cartridge or pen, and we'll give some numbers. And those people will come and demonstrate and all those things. So, but the patients will be hesitant to take. Unless a doctor says and educates them about this pen, the non-adherence will be because this that supply chain or what you call health educators are also they will not be competent so enough to answer to the patient's query. So if each doctor has a model pen or like this, and if they spend the 3-4 minutes with the patient, the adherence will definitely increase, and patients will listen to the doctor. Then one more important thing, when we are talking about this adherence and non-adherence, we do see a lot of GDM patients. See, in GDM, if diet fails, we have only option of insulin, because though some of the oral hypoglycemic drugs we can give during pregnancy, but we are still hesitant, like metformin or whatever it is. So, but what I want to say is adherence to the insulin in GDM patients is excellent. Almost 90 to 95% of the patients they will stick on. As I told you in one of the studies, only about 59% of the patients they were sticking on to adherent. The another 40% they were not. Whereas in GDM, about 95 to 98% of the patients they will stick on to this insulin, adherent to insulin. Yeah. Then what are the other practical things why there is non-adherence? This traveling patients, the patients who are travel for 5 or 6 days a week, a month or so, they are hesitant to take insulin because of while traveling they are can't. This vial and pen is difficult to carry. But this pen-like devices, easily they can keep it in pocket, they can try. So even for traveling patients, which needs traveling, we can convince the patients and take them to use these pens. They're quite easy. And we need not have to keep in the fridge. For a few weeks, we can manage without keeping the pen in the fridge. Bioavailability of insulin will not come down. That's one thing. And see, why patients are non-adherent? What's the fault? Is it fault by the doctors or is it fault by the patient? This cost factor and all, we should assess the financial condition of the patient. If a poor patient or a lower middle class person comes, if we write the expensive insulin, definitely he will not adhere. It will take for 15 days, 20 days. So any patient, when we are initiating insulin, we should analyze their financial status. The person who earns about 3,000 rupees a month, he can't spend about 600 or 800 rupees on insulin. For them, the vial or pre-mix 30-70 will be ideal, which costs around hardly about 300 or 400 rupees per month, which you can easily spend. So we should, but more than anything else, whenever we initiate insulin, we have to spend at least 5 to 10 minutes. We have to convince them. Definitely they will agree. And this non-adherence part will also come down. And one of the studies, just for curiosity, I was going through. In India, most of the diabetic, we have got a lot of diabetic patients. I don't want to tell the statistics. See, about 58, or I can say about 60% of the diabetic patients, whether in urban or rural areas, they are treated by general practitioner. I am repeating again and again. About 60% of the diabetic patients in India are treated by general practitioners. Another 35% are treated by well-qualified physicians, and only about 5% are treated by the endocrinologist. So, about more than 50% of the patients, they are managed by the general practitioners. And we know the mentality of our colleague general practitioners. They are hesitant to start insulin. They will go on increasing the oral anti-diabetic drugs. And oral anti-diabetic, this one drawback. And this one more thing, see, they have got 5-6 types of oral anti-hypoglycemic drugs. They have got their own limitations. Simple metformin, we can start with 250 or 500. We can't go beyond 2,000 milligrams per day. Even glimepiride, we can start with 0.5, 1 or 2 milligrams. We can go up to 4 or up to 6 milligrams, though 8 milligrams is the recommended dose. Maximum dose is up to 6 milligrams we can go. Pioglitazone we can 15 or 30, maximum 30 we can go, 45 rarely we write. Like this, any oral medication, SGLT2, they are once a day or twice a day are there. We can't increase any of the SGLT2. We have to give recommended dose. And even DPP4 inhibitors, whether teneligliptin or whatever it is, they have got a recommended dosage once a day or twice a day. We can't increase that dosage. But with insulin, we have got the advantage. We can start with small dose of 10 units, 12 units, depending on the body weight. We can go up to 60 units, 80 units. In many of the obese patients, we can go up to 120 or 140 units. So a lot of advantages are there with insulin. But only thing is we have to convince them. And this pen-like device is such a small label. It doesn't cause any pain at all. But convincing, educating patients to initiate this insulin is this one. So though there are a lot of barriers, but still we can convince the patients. See, in Diabetes, one of the landmark studies, which was done for so many years, it clearly showed that intensive diabetes control, whether with insulin or whatever it is, reduce 25% of the microvascular complications. Put 25% of the microvascular complications. We all know that even macrovascular complications will come down with the proper control or intensive control of insulin. In fact, we talk of early insulin initiation also. If I am correct, there are about 6 million people of diabetes. They are on insulin or insulin plus weight. So past, I think 15-20 minutes, I have tried my best. Some of the practical things. So, our medical advisor of authorities, and you people have listened to me for past 15-20 minutes. If there are any questions, I'll try to.
Yeah, so first of all, thank you so much, sir, for taking such an excellent informative session and taking us through all the various insulin non-adherence reasons, impact, sharing with your clinical experience as well. I now request all the delegates who are attending the session to please type the question in the chat box so that, sir can address your queries related to the insulin non-adherence. So yes, sir, there is one question. So the question is from Dr. Kumar. Sir is asking, in India especially, when you were saying about human insulin and insulin analogs, so what, according to your clinical experience or your opinion, in which subset of patients should human insulin be preferred over insulin analog or vice versa?
So this question is human insulin versus insulin analogs. See, human insulin has got a lot of advantages and few disadvantages of human insulin. We have intermediate acting, short acting, long acting. It's about 12 to 18 hours. It acts. It's cost beneficial. It's quite economical. But what are the disadvantages of human insulin? One is weight gain. Insulin is something it acts like a growth hormone. So human insulin, any person who is on human insulin will put on weight. Whereas it is not so with insulin analogs. Insulin analogs are more or less weight neutral. Whereas the cost of analog insulin, if I am correct, it's about 3 to 4 times more than the human insulin. 3 to 4 times. And most of the insulin analogs, they come in the pen and cartridge form. So automatically they will be more expensive. Whereas this human insulin, most of the companies who are produced, they bring it in the vial and cartridge form. So it's quite only economical. And probably the chances of hypoglycemia, they are more with human if compared to insulin analog. And allergic reactions we used to see for 20 years back. No, it's not so much with human insulin or insulin. So one is cost factor, second is weight gain, third one is hypoglycemia. When you compare with insulin analogs and traditional insulin. human insulin.
Okay. Thank you so much, sir. So the next question is from Dr. Rao. Sir is asking, can biosimilar insulin address the query of this rising cost of insulin, especially in Indian context? And what is your opinion on this? Take on this.
See, the word biosimilar is, it's not the same insulin. There will be some change with it. A lot of studies with biosimilar, almost on par with the innovative insulin. Biosimilar insulin are on par with the innovative insulin. The only advantage with biosimilar insulin is cost factor. If any biosimilar product, if it is on par with the innovative insulin, or if it costs more than the innovative insulin, it doesn't serve the purpose. The main idea of this biosimilar is cost factor. But they are on par. There are a lot of studies, and even government policies, whether in Indian or international, they won't approve if there are sufficient studies with biosimilar. Only then only they will approve to the market. But our allopathic system is not like Ayurvedic or homeopathic. The approval, unless they're on par with the traditional, what you call that, innovative insulin, government will not give you purchase. So I can say the cost factor will come down by 20 to 40%. Biosimilar insulins are on par with the innovative insulin.
Okay. So we have the next question. Can disposable insulin pens improve the insulin adherence as well as be cost effective over a long duration when compared with the syringe and vial method?
See, first I will tell about this cartridge and vial. The accuracy of insulin is much more with the insulin pen. It is not so with the vial and syringe, accuracy. Then second part is, when you use a vial and that traditional insulin BD or whatever it is, traditional pen, the needle size will be much smaller in the pens. Then third one is cost factor, hardly about 20 to 30%. And the fourth one is, pharma companies that quite kind enough to diabetic patients. When we initiate any patient on pen, they're kind enough, they'll give free pen. Most, except one company, I don't want to name that company. All the other companies, 5-6 companies, they're giving the pens. When we talk about pens, I told you the advantages of pens, the cartridges over the vials, especially for travelers, for workers, and the persons who take working people who take insulin in the afternoons, rapid acting or whatever it is. For them, pens are ideal. Pens with cartridges are ideal. And when we talk of pen, there are two types of. One is reusable pen. Second one is disposable. He told the word disposable. But disposable pens are quite expensive. Reusable pens. And most of the reusable pens are quite strong enough. They will be usable for 6 months, 1 year, sorry, 1 year, or 1 to 3 years. And most of the companies, they are kind enough. If the pen is damaged, they are kind enough to replace the pen, provided patients take the cartridges regularly. So I told you advantage. In India, the cost factor matters. In rural areas, you can't tell each and every patient to go for the pen. So it's since it's 20 to 30% expensive. So vials can be used, but except for the cost, the advantages of cartridge with pen are much.
Okay. So yes, so we'll take the last question for your today's session. So the question is like, from the Indian guidelines as come, like the RSSDI, as compared to the various international guidelines like American Diabetes Association. So in regards to insulin initiation and up titration or intensification, what should be preferred in the general clinical practice?
See, first and foremost, the first and important thing is guidelines are guidelines. Guidelines are meant to guide us how to manage a patient. Guidelines are not acts, guidelines are not. Just to guide the doctors how to treat a patient, guidelines are there. Each country, each association of each country, they will have their own. Even international federations also they do lot of that. There is no clear-cut guideline to start a patient. Also, clear-cut rule that this patient should be started. It's all individualized. See, a patient, if he comes with HbA1c, a new patient, if he comes with HbA1c of 10.8, I have to initiate him on insulin. I can't give him metformin as per the first line of therapy. I have to. So it's individualized. The initiation of insulin, it can't be a strict rule. If the HbA1c is 9.6, he should be on insulin. He can't be on oral. There's nothing like that. There's no rule. Guidelines are flexible, but each individual is separate, and each treating physician has to apply his mind to treat it. Okay. Yeah.
Okay. So once again, thank you so much, sir, for taking such an excellent session. And I hope all the clinicians who are listening to your session will be benefited definitely. And also they can approach you at a later date if they have any doubts with regard to the clinical practice. So once again, thank you so much, sir, and thank you to all the delegates for such a patient listening. It was a wonderful experience with interacting with you, sir. Thank you so much. Thank you.
Thank you, Doctor. I am Achyut, Doctor. On behalf of Vakar, Doctor, thanks for your wonderful speech, Doctor. Thanks for each and every doctor for attending the program, Doctor. Session hand over to Dr. Kashinath Dixit.
Thank you, sir. Myself, Manikanta.
Let me thank Achyut and Vakar for giving me an opportunity. See,
Thank you.
It was our pleasure, sir. Thank you.
See, the process of teaching is process of learning. Unless if there are speeches like this, I have to prepare. I learn so many things. I can get lot of data. So process of teaching is not showing my intelligence. Process of teaching is learning. So I have learned a lot. I have gone through so much of literature. So it is beneficial to me. That is important. Okay. Thank you. Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you, everyone. Have a great day.
Thank you, Doctor.
Yeah,
Have a wonderful day, ma'am. You too.
Yeah, thank you.